Hi, good morning, Pam. Good morning, everyone. Welcome to Pediatric Grand Rounds at the Children's Hospital San Antonio. I'm Luis Castagnini. I welcome you every week to this program. And I have a dual role because I'm welcoming you to this talk, and also I will be one of the speakers. Today we have the entire pediatric infectious disease team at the Children's Hospital San Antonio presenting. Let's see if this works. We have Dr. Jonathan Cruz. John will be presenting first. He'll be talking about epidemiology and transmission of COVID-19 in the pediatric population. He'll be followed by Dr. Summer Donovan, who'll be presenting on the clinical aspects of COVID-19 with a focus on the pediatric age group and also mention of the MIS-C syndrome. And then I'll finish with some comments about the diagnosis and treatment of COVID-19. As you probably understand, this is a topic of high interest for us and for everybody in our community. And our biggest challenge will be to stay on time. So, and we'll leave some time at the end for questions. Without further ado, I want to let Dr. Cruz start. I'm going to stop sharing my screen. Go ahead, John.
Yeah, hi, good morning, Luis. Luis, can you hear me and can you see my screen?
Yes, I hear you and your screen is visible. So, good.
All right, well, I'll go ahead and get started. Thank you for this chance to share about COVID-19. And first, before starting, I want to give a quick disclaimer. I think this is an important disclaimer. This is a dynamic situation, and in the 6 months' time since we've known about this virus, we've learned a lot, but there's still many unknowns, and the information that you'll learn about today is up to date as of today, and we're sure to learn more over the upcoming weeks to months. So in December of 2019, a cluster of cases of unexplained severe pneumonia were identified in Wuhan, China. And what started as a local outbreak quickly became a regional outbreak, and then eventually a worldwide pandemic. And as more and more cases accumulated for this virus, for this new infection, and more countries that were affected, there were several things that quickly became apparent with this emerging infection. First was the low rates of disease in children, and this was an especially surprising observation for a respiratory virus, but also the age-dependent disease severity, where the oldest adults were found to have the most severe disease. And lastly, the potential for outbreaks in congregate settings. We saw this early on with cruise ships. Eventually, this emerging virus would be named Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2, and the disease it causes was termed Coronavirus Disease 2019, or COVID-19. Within a month of recognition of the virus, there were cases reported in multiple countries, including the U.S., and this prompted the WHO to declare a global health emergency. And by mid-March, due to further worldwide spread, the WHO declared a global pandemic. And by late May, global cases reached 5 million. And then just 1 month later, in late June, global cases reached 10 million. This graph shows the current state of the pandemic from a global perspective. It shows the number of new daily COVID cases worldwide. Total during the pandemic, there have been about 13.4 million cases with over 500,000 deaths. And we're currently averaging about 200,000 reported cases per day globally. And as you can see on the graph, the pandemic continues to accelerate from a global perspective. And from a global standpoint, we have yet to flatten the curve. In the US, we are really kind of in an unprecedented stage of the pandemic. Currently, we are averaging around 60,000 new cases per day, and total during the pandemic, we've had about 3.4 million cases with about 137,000 deaths. And really, just to put that number in perspective, there are about 50 to 60,000 deaths during a bad flu season. In Texas, we've had about 282,000 cases and about 3,400 deaths. Currently, COVID cases in Texas continues to accelerate. We're averaging anywhere from 10 to 11,000 new cases per day. And unfortunately, recently we've begun to see a rise in deaths in Texas. And this pattern where there's an increase in deaths appearing about 4 weeks after an increase in cases, this pattern has been seen in other regions of the world that have experienced a large number of COVID cases. So now let's transition to the virus. Coronaviruses are a family of RNA viruses that were first identified in the late 1960s. They are widespread in mammals and birds, and they cause a variety of different infections in humans. The common coronavirus, of which there's 4, and they really have unfortunate names, the most common disease that it causes is the common cold, but it can also cause lower respiratory disease, and it may contribute to viral gastroenteritis. But in general, the human common coronaviruses have a worldwide distribution, and they cause year-round disease with seasonal peaks generally in the winter months. There have been 3 novel coronaviruses, SARS-CoV-1, which emerged in China in late 2012 before it kind of quickly vanished in 2003. And then MERS, the Middle Eastern Respiratory Syndrome, emerged in 2012 in the Arabian Peninsula, and it's still around. There are clusters and outbreaks, sometimes in the Middle East. The SARS-CoV-2 virus is, I think, did everybody put themselves on mute? The SARS-CoV-2 virus is thought to have an animal source, similar to the other novel coronaviruses. And the most compelling hypothesis is that this virus originated from bats through an intermediary host, namely the pangolin, these armadillo-looking creatures. SARS-CoV-2 has a pretty similar genes to SARS-CoV-1, which is why it got its name. These viruses encode 4 structural proteins, and really the spike protein, or the S protein, is the one to remember, as it's responsible for binding and entry into host cells. And it comes up in discussions on things like host immunity and vaccine development. SARS-CoV-2 utilizes the ACE2 protein for cell entry. And interestingly, a study in JAMA found that children had a lower expression of this protein in their nasal epithelium compared to adults. And this observation may be a part of the story as to why children experience mild disease with COVID. Now let's move on to transmission and what we know and have learned and observed about transmission with this virus. I want to talk about 2 metrics that epidemiologists use to help assess the contagiousness of a virus. The first one is the reproduction number. And the reproduction number is, it's also called R0. It's the expected number of secondary cases when assuming a susceptible population. So the reproduction number, or R0, for SARS-CoV-2 has been estimated to be between like 2 and 3, although there have been some studies that have estimated values closer to 5. But 2 to 3 is the general consensus. So what that means is, on average, a COVID-positive individual would infect 2 to 3 other people. And when you compare this with other pathogens, this value is higher than what's seen with seasonal flu, or that's been seen with pandemic flu. But it's lower than varicella and measles, viruses that are widely recognized to be spread through an airborne route. The secondary attack rate is another metric that epidemiologists use, and it's the percentage of exposed persons that acquire the infection. So in the numerator, you have individuals that are infected, and in the denominator, you have the total persons exposed. So the secondary attack rate, those numbers are generally estimated through contact investigations. And studies have varied on the overall attack rate of SARS-CoV-2, and the studies, just depending upon how they define exposure and whether asymptomatic persons are tested. But the general estimates are that the overall attack rate are around 5%, and I'm going to show you a study in just a second where the attack rate was even lower than that. The household attack rate is a similar metric, except the denominator are total household members, and the numerator are household members infected. And for the household attack rate, the studies, and there have been multiple studies looking at this, describe a household attack rate of about 15 to 20%. And this is pretty comparable to what's been described with flu. So SARS-CoV-2 is transmitted when virus from an infected host reaches the mucous membranes of the eyes, nose, or mouth of a susceptible host. And I'm going to talk about 3 potential routes of transmission for SARS-CoV-2. First off is droplet transmission. There's a widespread consensus that the virus is primarily spread through respiratory droplets. And respiratory droplets are large particles greater than 5 microns that are expelled by cough, sneezing, or talking. And given their size and weight, these droplets fall to the ground due to the effect of gravity. And that's really, they can only travel as far as a cough or sneeze would propel them, which usually is less than 3 to 6 feet or 1 to 2 meters. And in a second, I'll go through some of the evidence for droplet transmission. But first, I want to introduce airborne transmission and contrast the two. So while there's general consensus about droplet transmission, there is a little bit of uncertainty about the role of aerosols in the transmission of SARS-CoV-2. Aerosols are also called droplet nuclei, and these are small particles, less than 5 microns, that when produced rapidly evaporate, and then due to their small size and weight, they can remain suspended in the air for a prolonged time. And they can even travel beyond what a sneeze or a cough would propel it, so beyond 3 to 6 feet. And so there's a little bit of uncertainty about what role aerosols play with SARS-CoV-2, but I wanted to sort of lead with my conclusion, and on the next slide I'll go through some of the evidence of droplet versus airborne. But these bottom 2 bullet points really kind of summarize the majority view held by epidemiologists, public health experts, including the CDC and WHO, and infectious disease physicians. And it's namely that long-range aerosol or airborne transmission is very, very unlikely, but the role of short-range aerosols is less certain, particularly in certain settings, like during aerosol-generating procedures, where you have a high density of aerosols produced, or in unique settings where there's poor ventilation and there's prolonged exposure in a confined space. So there are really several observations that support the importance of droplet spread for SARS-CoV-2 over and above that of aerosol spread. And I want to just highlight 2 of them. If this topic really interests you, the reference at the bottom of the page comes from a viewpoint published in JAMA just this week by an infectious disease physician named Michael Klompus at Harvard. But if this topic interests you, I'd encourage you to read that article and explore his arguments. But the first observation that I think is important to consider is that the R0 and attack rate of SARS-CoV-2 is similar to other viruses transmitted by droplets. And that's in contrast with viruses spread through an airborne route like measles and varicella, which have much higher values. So with measles and varicella, when there is shared ventilation, a person in another room can acquire the virus. But for SARS-CoV-2, that just hasn't been described. And the R0 of SARS-CoV-2 is much lower than what would be expected if it were spread through long-range aerosols. And I think a second observation that's important comes from several reports describing scenarios early in the pandemic where you had critically ill adults hospitalized and they weren't recognized to have COVID until late in their hospital stay, even after they were intubated or underwent bronchoscopy. And interestingly, in these reports, the there was limited transmission to healthcare workers. So you had COVID-positive critically ill patients who were placed on contact and droplets, and healthcare workers were wearing medical masks, not respirators, and yet there was limited transmission, like less than 3%. And those few healthcare workers that were infected in these situations were those who had inconsistent mask use or were present during aerosol-generating procedures, like intubation or bronchoscopy. So I think if SARS-CoV-2 was predominantly spread through aerosols, then we wouldn't expect the medical masks to have been sufficient to protect these healthcare workers in these situations. There have been some other observations, though, that I think need explanation and really kind of make us pause to just immediately dismiss all forms of aerosol transmission. So first is that viral RNA has been detected in the air near patients, and that suggests the potential for the virus of being aerosolized. But viable virus or infection-competent virus has not yet been detected in the air. And that's really what our primary concern is, not whether aerosols can form that have the virus, but whether aerosols can lead to transmission. And then secondly, there have been some clusters in groups sharing indoor spaces that suggest some limited aerosol transmission. And these clusters have occurred in restaurants or choir practice, and I think in these clusters there is the potential for short-range aerosols leading to transmission, but I do think it's important to keep in mind that in these crowded indoor settings where there's various types of person-to-person interactions, that it can be difficult to separate aerosol from droplet, from fomite transmission. And also that these clusters, or sometimes they're called super spreader events, really seem to be the exception and not the rule for SARS-CoV-2. Again, if you're interested in this topic, I'd refer you to that paper cited at the bottom of the slide. So just in summary, the majority of experts, when considering the balance of the evidence to date, hold to a view that droplet spread is the primary mode of transmission, and that long-range aerosol transmission is very unlikely, though there may be the potential for transmission via short-range aerosols in certain settings. Transmission via fomites can occur when someone touches a surface contaminated by the virus and then subsequently touches their mouth, eyes, or nose. And there's not really a lot of empirical evidence of this route, for this route of transmission, but it really is assumed, given that it's well recognized that other respiratory viruses can be spread through fomites. SARS-CoV-2 can persist on surfaces for hours to days, but thankfully, since it's an enveloped virus, it can be easily inactivated with various types of disinfectants. There's been some question about the role of the fecal-oral route, and SARS-CoV-2 can be found in feces. The viral RNA can be found frequently. Only rarely can you detect viable virus, and to date there haven't been any descriptions of fecal-oral transmission events. It's been well recognized and well described that COVID-positive individuals can transmit the virus even before they develop symptoms, and I want to just highlight this paper that illustrates what pre-symptomatic transmission is and some of the research that we have to support it. It comes from Taiwan, where they identified the close contacts of the first 100 COVID-19 patients in Taiwan. They identified 2,761 people as close contacts, and they placed them on quarantine. While they were on quarantine, if they developed any symptoms, then they were tested for COVID. The infection rate among those contacts who were only exposed before the COVID-positive patients developed symptoms was 0.7%. And for those who had exposure within 5 days after symptom onset, the infection rate was pretty similar. And so the point I want you to take from this slide is that the infection rate during the pre-symptomatic phase seems to be pretty similar to that during the early stage of the illness. The last thing I want to just quickly point out from the study is that there were no infections among persons who who had exclusive exposure after the 5th day of illness, which suggests that the infectious period is really early on in the disease process. So I want to highlight the dynamics of viral shedding during a COVID infection. I think this can be helpful in understanding COVID. This was from an early study in China where they took 18 adults with COVID and they performed multiple NP and OP swabs on them during the illness. And in the graph, the y-axis is the PCR cycle threshold, where you have the lower the number correlates with the higher load. And then the x-axis is the days since symptom onset. So on the blue line, it shows the peak of, if you look at the blue line, it shows that the peak of viral shedding occurred very early, around the time of symptom onset. And this finding was different from the other novel coronaviruses like SARS-CoV-1 and MERS, where peak viral shedding occurs much later in the illness. And since then, there have been some additional studies that have shed light on virus dynamics. Viable virus can routinely be detected 2 days, sometimes earlier, before symptom onset. And for persons with mild to moderate disease, viable virus can persist for up to 8 days. And for those with severe disease or who are immunocompromised, it's thought that you can detect viable virus longer. So lastly, I just want to address the topic of how infectious are children. I think this is an important topic, especially right now where there are a lot of discussions about schools reopening. Children generally feel the community spread of respiratory viruses. That's well known and been well described with influenza. But in contrast, the evidence to date for SARS-CoV-2 suggests that kids may be less important to the ongoing spread of the pandemic. In pediatric case series that have been published to date, children diagnosed with COVID often have a known exposure to an adult with COVID. Often a household member, but not always. Similarly, there are a number of studies looking at COVID household clusters. And in these studies, children are rarely the index case, meaning that they're rarely the first person in the household to become ill. And then the last observation that suggests kids are less infectious than adults comes from COVID exposures in school settings. Now, there haven't been a lot of these, and the ones that have been published have been in other countries. But in these events, there have been limited number of transmission events from COVID-positive children. Now, this is early information. We're still learning a lot about the infectiousness of children, but these are surprising findings given the role that children generally play in the spreading of other respiratory viruses. So ultimately, we still need more research to understand what role children play in transmitting COVID. But based on what we know so far, it sure seems that children are more likely to acquire COVID from an adult rather than transmitting it to an adult or even transmitting it to one another. And so that concludes my section on the epidemiology and transmission of COVID. And I'll stop sharing my screen. There we go. I think you're up, Dr. Donovan.
Okay. Can everyone see my screen and hear me?
Yes, we can.
Okay, thank you. So thanks, John. My section of the presentation is going to focus on clinical manifestations of COVID-19 in children. So this is a pictorial that you can find on the CDC's website, and it lists the most common symptoms associated with COVID-19, which I'm sure you're all very familiar with. These include fever, cough, shortness of breath, and other flu-like symptoms. But one question that I had is, do these correlate with the symptoms that we see in children, and to what extent? So the next few slides, I'm going to run through some of the literature available on the subject. This first study was published in April in the New England Journal of Medicine. It retrospectively looked at over 170 children with COVID-19, and it looked at their different clinical manifestations that they had. So I want to point out that about 15% of children were completely asymptomatic. But then you can see that only about half of children had cough, about half of children had fever, And then a minority of children had between 5 to 10% had GI symptoms or upper respiratory symptoms like rhinorrhea or nasal congestion. This next study is also a retrospective review that was put out by the Morbidity and Mortality Weekly Report by the CDC. It looked at COVID-19 in children over an almost 2-month period from mid-February to early April, and then compared those symptoms with those seen in adults during the same time period. And as you can see, it agrees with the last study that I presented. About half of the children presented with cough or fever, a minority presented with shortness of breath, and then similar to the last study, a minority of children, around 10%, presented with either GI or URI symptoms. When compared with adults, children were much less likely to exhibit any of the symptoms of COVID-19 if you compare the second and the third column. And then specifically, children were much less likely than adults to present with lower respiratory symptoms such as cough and shortness of breath. The graph to the right also came from the same paper, and I thought it was worth mentioning. It might be kind of difficult for some of you to see, so I'll explain it. Each bar is broken down by age group. The blue part of each bar represents hospitalized children, and the black part represents non-hospitalized children. So the biggest outlier that you can see is that left-hand bar, which represents infants under 1 year of age. Over half required hospitalization. It's not really clear to me if this means that children under 1 have a higher severity of disease. Children under 1 get hospitalized for other things like fever and rule out sepsis, and this may be the case for a lot of these children. But several other studies have also suggested that infants under 1-year-old are at risk for more severe disease. Now, looking more specifically at severity of disease, this study included over 700 children with laboratory confirmed COVID-19. About 56%, you can see in that little red rectangle, had mild or asymptomatic disease. 40% had moderate disease, which was defined as radiographic evidence of pneumonia without hypoxia. About 2.5% had severe disease, which was defined as dyspnea, cyanosis, or hypoxia. And then less than 1%, or only 3 out of the entire 728 children, had critical illness, which was defined as ARDS, respiratory failure, or shock. And then I'll just quickly summarize this other study that looked at children with confirmed COVID-19 that presented to 17 different pediatric emergency departments in Italy. The children were categorized according to the severity of illness. And again, in this study, the majority of children presented with asymptomatic or mild disease. Only about 20% had moderate disease, and a very, very small minority had severe to critical disease. But while most children appear to have mild disease, there probably are some risk factors or comorbidities that are predictive of higher disease severity. The CDC's COVIDNet provides data regarding underlying medical conditions by age, and the most commonly reported underlying medical conditions in children with laboratory confirmed COVID-19 were chronic pulmonary disease, and this includes kids with moderate to severe asthma, also cardiovascular disease, and then immunosuppression related to any cause. There are some other conditions that are probably also likely to contribute to higher disease severity, and this includes high medical complexity, and these are those kids with trachs, home vents, G-tubes, also kids with complex genetic and metabolic disorders, complex neurologic disorders, and then severe obesity also likely contributes to high risk of severe disease. There are a couple of interesting studies that have come out looking at COVID-19 in supposedly high-risk pediatric populations. This first one looked at children presenting for cancer care in New York City who were routinely screened for COVID-19 with PCR. And among the patients that were tested, about 30, it was during a high prevalence time period, about 30 of them tested positive. And interestingly, only one of these patients required hospitalization for COVID-19, and it was the patient required non-critical care, so didn't have to go to the ICU. So based on this study, it doesn't seem that children with cancer are indeed at higher risk for severe disease. And then this other study looked at children with inflammatory bowel disease and COVID-19. Many of these children received immunosuppression, and a large number had their immunosuppression discontinued during the COVID-19 pandemic due to concerns for potential for severe disease. Unfortunately, a lot of these children that had their immunosuppression discontinued had a relapse of their IBD. But the children that were continued on their immunosuppression for treatment of the IBD, all of them suffered very mild illness associated with COVID-19, and none of them had flare-ups of the inflammatory bowel disease. I'll just quickly summarize the laboratory and radiographic findings that you can see with COVID-19. And I want to emphasize that laboratory findings are often completely normal, but when abnormalities are present, the more common ones are leukopenia, lymphopenia, neutropenia, and then elevated inflammatory markers, transaminases, CPK, and LDH. Radiographic findings can be normal in up to a quarter to a half of patients. But when abnormal, the most common abnormalities include ground glass opacities, patchy infiltrates, and if a lung ultrasound is done, you might see individual or confluent B lines. These findings can be unilateral or bilateral, and they can be present even in the absence of symptoms. There are a few more bizarre manifestations like COVID toes and loss of taste and smell, and I think I'm going to skip over this just for the sake of time. So that I have a little bit more time to talk about multi-system inflammatory syndrome in children. So as early as April 2020, reports started coming out from the UK of children presenting with symptoms similar to Kawasaki disease or toxic shock syndrome. And in these early reports, patients presented with persistent fever, hypotension, multi-organ involvement, and significantly elevated inflammatory markers. Most of the kids were previously healthy. Since this time, a lot of other reports have emerged in other countries. Some important things about this syndrome that have been noted is that with MIS-C, the cases seem to peak about 3 to 4 weeks after cases of COVID-19 peak. And then many of the children with MIS-C have a negative COVID PCR. This is not necessarily the case, but it's more common, and that they have positive COVID antibodies. These things suggest a probable post-infectious etiology for the syndrome. People have asked the question whether or not this might actually be Kawasaki, but epidemiologically, there are a few things that argue against these as being the same disease entity. The median age with MIS-C is 10 years old, whereas that for Kawasaki disease is about 2.5. And thus far, there have been no reports coming out of Asia of MIS-C, which we typically think of as being the epicenter for Kawasaki disease. This disease seems to disproportionately affect African American and Hispanic children, which we have also noted with acute COVID-19 infection. And in the next few slides, I've just really copied tables out of UpToDate because I think it nicely summarizes some of the clinical findings. There's a few things that I want to point out that are specific, seem to be more specific to this disease entity. 100% of children present with fever or have presented with fever, and a very high proportion, about 60 to 100%, present with GI symptoms such as vomiting, diarrhea, and abdominal pain. Some of the patients have abdominal pain that mimic appendicitis. Some other symptoms include rash, mucous membrane changes, conjunctivitis, and then neurocognitive symptoms like headache, lethargy, or confusion. Patients can also have sore throat, swollen hands and feet, and then interestingly, respiratory symptoms have not been a prominent feature in these children. When respiratory symptoms are present, it's most often due to severe shock rather than the virus itself. Many patients, in fact, up to 80% develop shock and require pressor support, and many have myocardial dysfunction, acute kidney injury, serositis, and hepatitis. Laboratory-wise, the things that are most important to point out are that many patients, in fact, up to 95% have lymphopenia and or neutrophilia. Mild anemia and or thrombocytopenia are common as well. This is something that is also different than Kawasaki disease, which almost always results in thrombocytosis rather than thrombocytopenia. And then patients also often have significantly increased inflammatory markers, elevated troponin and BNP, elevated liver enzymes, and elevated LDH and high triglycerides. If an echo is done, you'll find that many have left ventricular dysfunction, and a good number have been noted to have coronary artery dilation. And some people have theorized, though, that these children with coronary artery dilation may actually have had legitimate Kawasaki disease. And then I'm just going to skip my last slide, but I'll go through this one slide because I think it's important. Any pediatric patient that meets the case definition for MIS-C should be reported to their local health department. And if you need help figuring that out, we're all, I think, within the division happy to help do that. But this is the current case definition, and I copied it directly from the CDC's website. Patients must be under 21 years old, present with fever, have laboratory evidence of inflammation, be hospitalized, have at least 2 organ systems involved. There must be no alternative plausible diagnosis. And then they have to be positive for COVID-19 in some form or fashion, either have a positive PCR, a positive antibody, or they have to have a close contact with that is COVID positive within the 4 weeks preceding symptom onset. Even if patients meet the full Kawasaki disease criteria, they should still be reported if they also meet the case definition for MIS-C, and then MIS-C should be considered in pediatric deaths with evidence of SARS-CoV-2 infection. And then I'm going to skip my last slide for the sake of time and turn it over to Dr. Castanini. Sorry, let me.
Thank you, Summer. Can you stop sharing your screen?
Yes.
So I can? Thank you. So I'm going to talk about the diagnosis and treatment of COVID-19. And I'd like to start with a few slides on diagnosis. There are different modalities on how we diagnose COVID-19 in patients, whether it's a child or an adult. Molecular techniques are the current reference standard for COVID-19 diagnosis. This is done by PCR, detecting the SARS-CoV-2 virus. It can be done on samples obtained from the upper or lower airway, blood, urine, and stool. Our current instruments are not validated for blood, urine, or stool. These are mostly done on research settings. Serology has also been utilized in diagnosis, and I have another slide talking about serology and why it's useful or why it may be tricky to interpret those results. Antigen detection has recently been used. This is a very specific test. It's detecting the actual virus. It's very specific, but it's not very sensitive. So the CDC recommends that if you're using antigen detection, that you confirm that with a PCR if the test is negative. Viral culture is also used, but also in research settings. Molecular diagnosis is not perfect, but it's the gold standard. We emphasize that we do not test by PCR the day of exposure, so this is very important. The highest detection rate happens between day 5 and day 8, so that's the time where is the most valuable to make this to use this test. It can be the PCR positivity is highest on the BAL samples, up to 93%, and then followed by other respiratory samples like sputum or nasal swabs. This is what the CDC currently recommends collected by a healthcare provider. Nasopharyngeal is the most used technique to obtain the sample, but it can also be obtained from the oropharynx or from the anterior nares. In this slide, I wanted to show what the data shows on serology and its performance when it's combined with PCR. As you can see here, the first week, the PCR is the best, with serology not being very effective in detecting infection. The second week, serology is a little bit better, and you decrease your detection rate with PCR. What seems to be the best is after the second week of infection, PCR and antibody combined is the best performance. I like to warn everybody that even on high specificity testing, when there's low prevalence of disease, the positive predictive value may be very low. So doing serologic tests has to be interpreted cautiously on low prevalence settings. In this graph, you can see the timing. Here you have the serology in the dotted lines in purple and green. It starts going up after the first week, during the second week of disease. but the highest detection level for PCR is up in during day 7 here, and for serology is up here after the second week. Let's talk about treatment. And I like to point out that treatment modalities are not currently studied in children, or the data is not available. So everything I'm going to show today is in adult data. There are multiple treatment options that have been reported, antiviral agents. I'm going to focus here on remdesivir and hydroxychloroquine. Some immune modulators like steroids, convalescent plasma is what I'm going to be talking about. Other treatments like ivermectin and azithromycin, I'll mention azithromycin briefly, but for the sake of time, I'm going to focus only on the ones I've marked. Let's start with remdesivir. This is a cartoon showing SARS-CoV-2 infecting a host cell. It enters the cell and then it releases its RNA here. And it requires RNA-dependent RNA polymerase, and that's where remdesivir works, right here. So remdesivir was studied first in Ebola with unsuccessful results, and it was then used for SARS-CoV-1. And it was shown in vitro to inhibit the replication of virus. So this medication was repurposed for SARS-CoV-2. And this is the biggest study that was published on remdesivir. Was May 22nd. And they included, in these particular studies, a double-blind randomized placebo-controlled study with a little over 1,000 patients. They included 68 sites around the United States and 21 in other countries in Europe and Asia. So in this particular study, remdesivir was better than placebo in time to recovery. So there was a 31% faster time to recovery than those who received placebo, and that was 11 versus 15 days. That was statistically significant. Here you have the Kaplan-Meier curve, where you can see that remdesivir performed better in time to recovery. There was also an indication that it will help with mortality, although this was not statistically significant. There was a decreased mortality rate from 11.6 to 8% in this particular study. In that study I just showed, they used 10 days of remdesivir, but a subsequent study revealed that a 5-day course of treatment may work as well. And this is the conclusion of these authors. In patients with severe COVID-19 not requiring mechanical ventilation, our trial did not show a significant difference between a 5-day course and a 10-day course of remdesivir. With this data, the NIH guideline recommends the use of remdesivir for patients with moderate to severe COVID-19. Again, we do not have data in children. Hydroxychloroquine. This is the same cartoon I showed before. This is where hydroxychloroquine is thought to work at the time of the membrane fusion and endocytosis, but it also has some anti-inflammatory and immunomodulatory effects. As we all know, hydroxychloroquine is used in some autoinflammatory diseases, so that might also be a potential use for this disease. In this particular study, this is the first study that was published, or the largest study published in New England Journal of Medicine. It was an observational comparative study. They compared hydroxychloroquine with no hydroxychloroquine, and the outcome they were looking at was intubation and death. They included over 1,300 patients. And in this Kaplan-Meier curve, you can see that there was no difference between the group that received hydroxychloroquine and the group that didn't. So in this particular study, the conclusions is that the administration of hydroxychloroquine was not associated with either a greatly lowered or an increased risk of the endpoint, which was intubation or death. Another study published 4 days later was a retrospective multicenter cohort study, and this was all adult patients with confirmed COVID-19. They looked at 4 different arms: hydroxychloroquine in combination with azithromycin, hydroxychloroquine alone, azithromycin alone, or just the standard of care with no medication, none of those medications provided. The primary outcome was in-hospital mortality, but they also looked at some side effects of these medications. As we all remember, these medications may have some cardiac-related side effects. So the authors looked at that as well. They included a little over 1,400 patients. The more than 700 received combination of hydroxychloroquine and azithromycin, and a little over 200 in each of the other arms. This is the Kaplan-Meier curve. As you can see here, the in-hospital death was highest in the group that received the combination therapy. So hydroxychloroquine plus azithromycin was the worst of all the outcomes there. Hydroxychloroquine alone and neither drug are in that line, and then azithromycin alone.
Luis, I think we may have lost you. It seems like we've lost audio for Dr. Castanini's portion of the presentation. I think maybe we can take some questions until we wait for him to get back on. If anyone has any questions, you can either ask or put it in the chat.
Yes, this is Dr. Dean. I had a question on the different presentations of MIS and the fever with GI symptoms can present mild. I think there's a risk for missing this in the emergency room. Is there any educational efforts being put out to watch for this presentation?
I can take that question. I don't know that there's any, well, I don't know that there's any educational efforts per se, but there probably is a spectrum of disease that occurs with MIS-C. And one of the important things to remember about the case definition is that it has to involve equal to or greater than 2 organ systems. And so I think it's important, if you suspect MIS-C, to go ahead and you can start a laboratory workup. So maybe have a high index of suspicion in kids that have persistent fever and GI symptoms. And then start a laboratory workup with a ESR and CRP and possibly a ferritin, CBC with diff, things to look for. Lymphopenia are one of the more common findings, to look for elevated inflammatory markers. And I would say if those are normal, that it's less likely to be MIS-C, and that you can likely relax a little bit.
Hello? Hello, Pam, can you hear me?
We can hear you.
Hello, okay, sorry. I was talking to the air for a while there. I apologize for that. Okay, I'm gonna go back to where I was before. I think this is the last slide I showed. Talking about hydroxychloroquine, and This is a retrospective multi-center cohort study. And in this particular study, they looked at 4 different arms: hydroxychloroquine and azithromycin, hydroxychloroquine alone, azithromycin alone. This is the number of patients in each of the arms. They included a total of a little over 1,400 patients. In this particular study, hydroxychloroquine plus azithromycin was the least favorable outcome. In hospital deaths was higher in the group that received hydroxychloroquine plus azithromycin. This particular study, the authors concluded that treatment with hydroxychloroquine and azithromycin, or both, compared with neither treatment, was not significantly associated with difference in hospital mortality. Cardiac arrest was more common in the group that received a combination therapy. This particular study showed there was an effect, a favorable effect with hydroxychloroquine. This study was done in Southeast Michigan by the Henry Ford group. And in this particular study, hydroxychloroquine alone was the most favorable outcome. This study has been criticized because the patients who received hydroxychloroquine were more likely to have received steroids as well. And I'll show you in the next slide what the steroid effect is on COVID. Also, patients who received hydroxychloroquine were younger than those who didn't. The authors acknowledged this limitation, and so they did a propensity matched analysis on a subgroup of 380 patients, and hydroxychloroquine was still protective, although the effect was not as robust as in the entire cohort. So there you have studies showing that hydroxychloroquine does not work, and this particular study is the largest study that shows that it does work. So there's still some discussions in the scientific community on whether hydroxychloroquine is an effective treatment for COVID. Most experts agree that hydroxychloroquine should not be given routinely outside of a clinical trial, however. The NIH guideline does not include hydroxychloroquine in their treatment modalities. Just to mention that hydroxychloroquine was published. These 2 studies were retracted because the source of the data was not able to be verified. Convalescent plasma. Convalescent plasma makes sense. We used convalescent plasma in the 1918 pandemic against influenza. And so there are multiple anecdotal reports of small case series of 5 or 10 patients that have improved in survival and in their laboratory findings using convalescent plasma. There are still a lot of studies ongoing with this intervention. The largest study is an open label multi-center randomized trial that they looked at the use of convalescent plasma plus standard treatment versus standard treatment alone. And in this particular study, in all the patients that were analyzed, there were 103 patients total. The convalescent plasma did not have an effect on improvement. However, when they looked at just a severe disease, in this particular group, convalescent plasma was effective, and that was statistically significant. For patients that have life-threatening disease, there was no difference in the use of convalescent plasma on their outcomes. So there's the question still out there for convalescent plasma utility. The authors concluded that among patients with severe or life-threatening COVID-19, convalescent plasma added to standard treatment compared with standard treatment alone did not result in a statistically significant improvement, although they did mention the effect on severe disease, and we still need to look at this. This particular study had to be stopped early, so they were not powered enough. And they stopped it early because of the decrease in the number of cases where the study was done. And finally, I'll just mention the recovery trial, which is the randomized evaluation of COVID-19 therapy done in the UK, in the University of Oxford. It's unclear benefit of the use of steroids in SARS patients in the SARS-CoV-1 outbreak in the year 2002. They had some studies that showed some benefit and some others that did not. In fact, there were some studies that showed some detrimental effects. So it was unclear at the beginning of the pandemic if steroids will be beneficial for patients with COVID. In this particular study, they randomized patients to receive either 6 milligrams of dexamethasone or the standard of therapy. They included 2,100 patients, and 4,300 were randomized to usual care. In this particular study, the dexamethasone arm had a decrease in deaths by 1/3 in ventilated patients and by 1/5 in patients who were receiving oxygen only. There were no benefits in patients who did not require respiratory support. The number needed to treat with dexamethasone was 8 in ventilated patients to prevent 1 death, and 25 in those receiving oxygen to prevent 1 death. This is again the Kaplan-Meier curve of all participants, 6,000 patients. Dexamethasone, this is mortality, and dexamethasone improved survival in this particular study. In this graph is only patients that received mechanical ventilation, more than 1,000 patients in that group, and dexamethasone had a very robust and good effect on survival. So that's what I have for you. I hope we have some minutes for some questions. We lost, 3 or 5 minutes with my, when you lost me. But in summary, transmissions occur primarily through respiratory droplets. Individuals with COVID are most infectious in the early stages of the illness. Most children experience mild COVID-19 compared to adults, but severe disease can occur or miss C as well. Molecular diagnosis is the modality of choice to diagnose COVID-19, and data on treatment options are lacking in the pediatric population. However, for severe disease, it is reasonable to consider remdesivir and dexamethasone until more definite data is available for kids. I'll stop there, and I will open up for questions. We have a couple more minutes.
Yes, this is Dr. Dean. Dr. Castagnini, you're on the Community Response Coalition Committee to reopen the schools. You met yesterday, 2 weeks before the schools were to reopen. Did you decide on a criteria for safe reopening, such as less than 5% infectivity?
And thank you, Dr. Dean, for your question. I've been on vacation this week, except for today because of Grand Round, so I was not able to participate in the meeting yesterday. I'm not sure what was decided, and so I'm not able to answer your question on what the committee decided. I am part of it because they asked for my involvement as an advisor, and I have been participating through emails and sharing my opinion on what might be the best way to reopen schools. But there are a lot of moving parts on that decision. There are a lot of things that need to be considered. It's my understanding that yesterday the Independent School District of San Antonio decided to continue online school until past Labor Day. I don't know if John or Summer have more information, or anybody else in the audience would like to comment on that.
Will you be able to keep us up, the pediatric community, up to date on what's going on in the city?
Yes, absolutely. I will get more information on that, and I will share with either the San Antonio Pediatric Society or through the any other means that we can to keep everybody informed. But these will be publicly available, I'm sure, as decisions are being made.
There are a few other questions in the chat box that people have left. One of the questions is regarding prophylaxis with vitamin C or vitamin D for children. Do either of you have any information about that? I do not.
I have not seen any studies looking at those interventions or the use of vitamins to prevent COVID. The only studies I've looked at post-exposure prophylaxis, there's one on hydroxychloroquine, and the result of that study was that it's not helpful in preventing. So I have not seen any study. I don't know if John, have you seen anything with vitamin C or D? And there's a comment in the chat related to school opening, and it says that NEISD, NISD, SAISD virtual first 3 weeks. Not all districts have announced plans. So as I mentioned before, I think up to Labor Day is going to be virtual schooling.
I just wanted to finish answering Dr. Dean's question about MIS-C earlier and diagnosis of that. There are some really big children's centers that have come up with pathways and algorithms for diagnosis and management of MIS-C. These are places like CHOP and Texas Children's Hospital, and I'd be happy to get you those resources if you feel that you want them. You can email me, and I'm happy to get those to anybody.
How do I access your email?
Summer.donovan@christushealth.org.
There's another question in the chat that says, can we comment on the association between COVID and diabetes? Anecdotally, we have seen several new onset diabetics who are also found to be COVID positive. My comment is I've seen a couple of studies looking at that association. There seems to be an association between the two entities. Of course, there's still a lot we need to learn, but that particular study I'm referring to shows a link. You know, how strong that is, only time will tell, but there is some association that has been reported, yes. Any other questions? It's a little past 8:30, so there's another question here from Megan O'Brien. Given that MIS-C seems to be a post-inflammatory issue for pediatrics, any concern about the same thing happening with post-vaccination in children?
That's a good question. I can take that one since I covered the MIS-C section. That's a really good question, and I don't think that concern has been brought up to date. So I think part of that is we need some more time to be able to tell. One of the vaccine trials that was done in humans just came out. The results of that just came out, and so we see the peak of MIS-C occur about 3 to 4 weeks after the peak in COVID-19. So I would say we need to wait and see.
Any study showing how much COVID-19 affects kids with autoimmune disorders?
There are no studies to my knowledge, but it's theorized that kids with immunosuppression may be at higher risk of severe disease. However, some of these studies, such as the ones that I presented in children with for cancer care, and then children with inflammatory bowel disease on immunosuppression, that doesn't really seem to have played out in studies that they're at higher risk for severe disease. So to my knowledge, there are no studies specifically looking at kids with autoimmune disease, but I would say that theoretically, you would think that children on immunosuppression would be at higher risk, but there's just still so much that we don't know, and things that we sort of assumed to be true have not really been true in studies.
Hi, Luis. I see a question from Joe Ferreras that I think I can take. He asked if there's any, at what point do does the infectiousness of children reflect that of adults? And just to clarify, you know, my comments about how it seems that children are less infectious than adults really is based on just the evidence to date, and I don't think we yet have enough evidence to classify the infectiousness of preschool age versus school age versus infants. I think that it's possible we could get that data over the next several months by looking for signals in just the differences in transmission dynamics in various settings where children congregate together. For instance, if there are differences in transmission between child care centers versus high schools, those differences would kind of inform that sort of assessment. But I don't have an answer, Dr. Ferris, to your question. Just I don't think we have the evidence yet.
There was another comment that says that maybe we should have another grand rounds just to talk about vaccine development. I had a few slides on that, but in the interest of time, it was going to be very difficult to cover all that topic. And we are actively thinking about maybe inviting an outside speaker to talk about that. So stay tuned. Is there any literature supporting standard treatment for Kawasaki, namely high to low dose aspirin for MIS-C in kids with cardiac involvement?
These algorithms and pathways that I mentioned before to Dr. Dean, some of them do mention using aspirin for those children that have coronary artery dilation, because it's kind of confusing whether, how much overlap there is with Kawasaki disease or if it's a completely different entity. But yes, I'm not sure that there's, so the literature that I've found supports using IVIG plus or minus aspirin. And that's really kind of what you see with Kawasaki disease treatment as well. But I think that currently what most centers are doing is using aspirin for those children that do have signs of coronary artery dilation.
Very good. Well, thank you very much, everyone, for joining. We've gone over a little bit. It's 8:35, but we appreciate, and I apologize again for that loss of audio. I got disconnected, but I hope that everybody got some information that's useful for your own practices. If there's any other last-minute questions that you want to ask, we're here still. If not, thank you everybody for coming, and I'll see you next week. Don't forget, next Friday we have another Round Rounds event, so please join us as every week.